Thank you for joining this morning. My name is Steve Rotman, Chief Executive Officer at WISHIN. Appreciate you taking some time to join us today for the education session related to the data sharing participation agreement modifications that have recently been made and will be effective January 19th. A couple housekeeping items. If you choose, please introduce yourself in the chat. Also, use that chat feature to uh, put any questions or comments that you'd like addressed, and we will answer those through the chat, or we'll come back to those in the Q&A portion of the session today. All right. I'm joined by a few folks also from WISHIN. Um, Greg Staddert, a Director of Ops, Carol Gray Eunice, Community Outreach Specialist, Matt Jago, Director of Pop Health. I believe I saw Tom Roll. Yeah, Tom Roll. He's our Communications and Outreach Specialist. And Laura Witter, she is our Director of Projects and really our tech lead related to Health Information Exchange. Ashling Meehan Fanning, um, Operations Support. If I missed anybody, I'm sorry. I'm trying to go through this list. You can also introduce yourself in the chat. So with that, let's get into it. Just want to state the purpose of today's meeting here. This time is to educate all on the approved changes that went through this change process, and we'll go through this in just a bit. There has been appropriate and exhaustive review of all changes, discussion with the participant advisory board, um, the board of directors, and as I mentioned previously, these changes will go into effect January 19th. We'll go through the changes pretty quickly, and then, as I mentioned previously, we'll field questions at the end. We're not going to use this time to defend or dispute any of the changes, but happy to talk through um, the desired results of these changes and how this will bring better care to the patients you're caring for in the state of Wisconsin. So to discuss the process, there's a participant advisory board as called out in the data sharing participation agreement. It's made up of a diverse representation of all participants. So there's critical access hospitals, large health systems, health plans, the state of Wisconsin representation, and a few others. There's 15 individuals on this committee or advisory board, and from here on out, I may uh, revert to saying PAB. So when I mention PAB, it is the participant advisory board that is charged with reviewing any and all changes before it would even go to the board. If it doesn't pass muster through this committee, we don't move it to board for adoption and modification of the PA. Through this early part of this year, starting February, March, we started bringing the PAB together to discuss a number of changes that were substantial enough uh, to require their input and review. And between February, March, and July, there were several meetings to discuss and review as a group, and also one-on-one with hospitals, health systems, others with their legal departments, with their compliance departments to make sure, again, that the changes were aligned with HIPAA, treatment payment and operations, state and federal law, etc. And that the organizations representing the whole, these individuals on the PAB, were comfortable with the changes that drove efficiencies, drove greater visibility into patients, again, with the outcome of better health. There was a vote by the PAB July 11th to move all changes unanimously to the WISHIN Board of Directors. The board, actually, I'm sorry, the executive committee of the board met to review, made some slight modifications that were then moved to the board for adoption during our September 23rd board meeting. And from immediately following the adoption, the requirement is to send a notification to all participants, which we have done both by snail mail and email, and then communicated further with through our newsletter and such. And the time requirements for that notification period is no less than 90 days. That is why between September and the effective date, we are taking this time to educate all of our participants on these changes. So, last thing before we get into the changes themselves are quick type of rationale of why these changes. And the reason for many years through the pandemic, we held any modifications, but fielded a lot of responses. So there's been several requests from current participants and prospective participants that wanted to see an expanded capabilities of the WISHIN network, how the data could be used, who could access the data, all leading to greater demands for interoperability, alignment with what's coming from the federal government, and overall moving WISHIN from a transactional health information exchange where data is submitted and sent and accessible and redisclosed to more transformational. How can we best use this data to inform patient care, inform transitions of care, et cetera? So that is some context and an overview of the process that we took. So into the changes themselves, quick summary, we are aligning public health activities or aligning public health authority with federal regulation. And we'll talk again through each of these one by one, but wanted to give you a quick summary. We are including aging, disabled resource centers, and if I mess that up, I apologize. But the ADRCs have been a huge component to our network as of late, and wanted to call those out specifically. WIC agencies, which are knocking at the door for participation and some funding opportunities. We thought it was appropriate for those WIC agencies to be called out specifically, and Community Information Systems, CIS. We are doing work in the Brown County area with a CIS there and wanted to call those three organization types or agency types out specifically. Explicitly authorizing the exchange of SDOH. We all know the importance of health-related social needs or SDOH data. We'll dive into that a bit more, but this lays a foundation to be able to exchange seamlessly SDOH data. Committing payers to more meaningful communication as it relates to care coordination activities, where the impetus of that transition of care coordination efforts are driven out of WISHIN data, that there's essentially a closed loop with the provider, what activities are being had with those members or patients. Harmonizing existing payer access use cases, we'll dive into that further. Addition of risk adjustment, risk management, utilization management to the existing use case. This has been a call out for a number of years from our health plan participants, and I'm glad we're able to add that. And then last thing we'll discuss is population health analytics, but data assets that we can derive out of the WISHIN asset to provide visibility beyond a patient-centric view. Again, if there's any questions or comments, you can raise your hand or use the chat feature, and we'll address those. So change to 2.4a. Under Section 2 of the participation agreement, this section handles the permitted users. So within here, we have, as you can see, struck reporting purposes, as it's been a limitation for participation for public health agencies, and to carry out the public health activities that we really saw surface through the COVID pandemic, and align this use to 45 CFR 164.512. In that federal regulation, it states specifically use and disclosures for public health activities. So we're aligning to that federal regulation. We see this as an opportunity, as it states here, to strengthen the public and private interoperability that is so desperately needed. We are adding, as I mentioned previously, ADRCs, WIC, and CIS. And for those in question, what about those organizations that don't have authority to access EPHI? Or we are aligning access in accordance with HIPAA privacy and security rules, and obviously to federal regulation and state law. So where these organizations, especially for purposes of benefit determination with ADRCs, they are receiving clinical information and making those requests on behalf of through a HIPAA authorization from a patient, we are expediting that benefit determination process with these agencies, and look to enable women, infant, and children programs in the community information system. While limited now in Brown County, there's a great opportunity to expand this in other geographic areas across the state. Moving on then to in addition to Section 3. 3.11 is an entirely new section of where data, so under Section 3, this calls out what data is permitted to be sent to WISHIN, and then therefore have WISHIN redisclose in accordance with the permitted uses. And we believe, and so did our participants represented on the PAB, believe it's time to add the explicit authority where WISHIN can receive SDOH or HRSN data, store it, parse it, and then make it available through the WISHIN network. We are already seeing SDOH, HRSN data in the network. So the opportunity and availability does exist to some extent within the new system, and I won't dive in too much into the new system capabilities, but I really want to call out that the underlying infrastructure of this new system is US CDI version 3 compliant, or I'm sorry, will be. And that will allow those discrete SDOH data elements to then be available through FHIR resources as we build those out in 26. All right, moving on to then, I'm sorry, I should call out under SDOH also the opportunity to receive and exchange social screens. And while that is not yet built out, this modification will allow those activities to carry out. Modification number 4 are definitions. So we wanted to, one, define social determinants, social drivers of health, and health-related social needs, just to make sure that we're aligning to CDC, as it says. It's an adapted definition from CDC. And the other modification to definitions is being more explicit about who is represented on the participant advisory board, and how changes to that committee will be determined and directed through the WISHIN board of directors. We do have a process through a governance board, and that's what we're aligning to. Modification 5, Schedule 1 to Attachment 1 outlines the services that WISHIN offers, and the requirements of participants in WISHIN, how to carry out those services. Under Schedule 1 to Attachment 1, when payers were permitted to access WISHIN for the permitted uses under use case 8, which we'll get to soon, there was a condition of participation that was memorialized within the PA under 3.3. So payers' access to the WISHIN Pulse system had conditions where those healthcare payers needed to also share data into the network. And we have a committee, a subcommittee that oversees the payer access policy. This group has not met in a number of years. However, there are plans in 26 to reconvene this committee, and then now really establish processes and technical specifications for data to be contributed. But as we were looking at changes to use cases 7 and 8 specific to health plan access, the providers on the PAB stated, as I mentioned previously, a need for better communication, as there is coordination happening between the providers and the health plans, so that we're reducing confusion on the patient / member side. So that is some added language here. Also, that calling out explicitly, which has always existed, that the providers contributing data can elect to opt out of sharing some information related to specific use cases under use case 8. Again, use case 8 we will touch on shortly. There are now 5 permitted purposes of use, and again, stating that healthcare providers have always had the option to opt out. and we through the PAB thought it was appropriate to explicitly call this out under 3.3. Okay, moving on then to modification to use case 7. As mentioned previously, payers have had access to WISHIN for some number of years. That was effective in 2018. We have been operating under the assumption that use case 8 supersedes number 7 here. This is number 7. And the redlining and modifications really harmonizes the language, which admittedly was an oversight when we added use case 8, not to better memorialize the language that should have existed under 7 to defer to 8 and the broader use without explicit authorizations that now exists under 8 and has since 2018. So this is the purpose of use case 7. And use case 8, we are adding to the permitted uses risk adjustment, risk management, utilization management to the existing 4 permitted use cases: claims adjudication, prior authorization, care management, and collection of quality data. So effective January 19th, we WISHIN will enable an additional role where payers can identify users within that health plan to access WISHIN for under the role of risk adjustment. And those access to the data, those that access the data under any of these permitted uses are audited and tracked, just like all access to the WISHIN network. But this limits also the maybe I'll say cross-pollination across the health plan. So we're honing in on individuals' access into the network for only these permitted purposes. That is driven through health plans sending WISHIN a member roster on some cadence that they determine is appropriate for their organization. When we receive that, we process it to open the gate to member or patient information, again, only for those specific roles that user is authorized. Let me also say under risk management, and I'll go back, apologies. This is also going to help drive some of the value-based arrangements that exist and enable WISHIN to collaborate broader between providers and payers. And as we look at the benefits to healthcare providers, is how we can look at the risk adjustment data for FCC or HCC coding purposes, and how that could drive RAC adjustments for payment purposes. So we see a lot of opportunity through just adding this new use case. And then the last modification that is being made here is the addition of use case 10. So use case 10 allows now participants to use WISHIN data for aggregating population health data assets. This could be to drive at-risk or insights into at-risk populations, interventions, predictive insights, but it really helps transform the value of the WISHIN asset and allows WISHIN to create these population assets for payers, providers, public health, et cetera. So we're at the infant stage of developing some opportunities. There's a number of conversations now leading to the effective date of January 19th, but already we're hearing so many opportunities that will come of the just this one additional use case. And these opportunities will ensure WISHIN's continued sustainability and availability as, again, we move from transactional data exchange to more informing transformations for the populations and individuals that you serve. So with that, um, happy to open it up for questions. I would ask any of my team members first before we go into Q&A if there's any commentary that they would like to add.
Steve, I thought you got it covered. Thank you.
All right, thanks, Greg. So again, happy to address any questions. We're here. We're here as a sounding board and make sure that you have the information you need. And hope this brings insight into why we've gone through this process. Hi, Beth. I see you're on video. There you go.
Hi,
How are you?
I'm good. How are you?
Very well, thank you.
Good. I was just going to ask a question, if that's okay.
Please.
Um, So yeah, thanks for this overview. So I work for public health and the WIC program, actually. So you mentioned WISC, so thanks for the shout out. Um, one and it works so great for us. We're able to get heights and weights from medical providers, and then we could potentially do the client's appointment remotely if they recently saw their healthcare provider. So I just wanted to add that it works so great for us, and participants, of course, love those remote appointments, one less place to travel. So. Um, my question, and I think number seven maybe talk to something about this. Once in a while, if we're doing an appointment, I'll say something like, "Oh, I saw, you had a doctor's appointment recently. How did it go?" And sometimes they say, "Oh, like where did you see that?" or something like that. And I just wanted to like clarify that. Like, so would the doctor's office, if they participate in WISHIN, be doing any kind of disclosure with the participants, like? Your data may be shared, or like, should we be doing something like that? I just wanted to kind of pose that question, or if, yeah, like we're missing anything, or if that's,
Sure. That's a great question. And Laura Witter is also WISHIN's privacy officer. So she does most, if not all of the onboarding and most, if not all of the training as well. And as part of that, I'll wait till she gets off a mute. Maybe I'll kill some time, but there is um, we have we inform our participants to update their notice of privacy practices or have some mechanism to share that their data will be shared with WISHIN as the HIE in Wisconsin. We do not audit that. We just inform that those organizations should go through that process. So WISHIN, I'm sorry, Laura, anything to add there as far as notice? But under Wisconsin state law, it is not a requirement to notify patients with as their data is being shared into the network. And I can dig up that state statute. I have it somewhere. If that would
And
be
Steve,
helpful.
I think Laura had to jump temporarily, but yep,
Oh, okay.
you hit it. So we're an opt-out state, which means as part of the consent to treat at facilities across the state, patients, as part of that process, opt in to have their data shared through WISHIN. And we have, if you ever encounter anyone that's interested, there's a really straightforward opt-out process for individuals that don't want to participate in the network. So.
Oh, so not necessarily a health system, but like a participant could also opt out.
Yep, or
I
individual
see.
patients.
Okay,
Yep.
sure. Yeah, and I can't say anyone was ever like mad, mad or anything like that. I just felt like too, we always have to do like sign consent before we like refer to a program. So it just got me thinking like, are we supposed to be doing anything else on our end? Yeah, so I just wanted to clarify that. So
No, through the data sharing participation agreement, it is um it's a reciprocity agreement, and it's a an agreement that not only organizations execute with us, but you're executing it among all participants. So everybody's playing by the same rules. Um, and those are explicit. That's why there's this change process and accountability and notification to participants that that you have an opportunity to review all of these changes before they become effective. But as far as so there's nothing that you have to be doing other than complying with your own organization's privacy um, policies.
sure. Yep, that sounds good. And so that's kind of what I was thinking, like, when I went to the doctor too, they give you that yearly annual, I think, notice of the privacy agreements that you sign. So use something like that. If they're in WISHIN, it'd probably be listed on there that the participants are getting. Let me see some headlines. Okay, that's kind of what I thought
Yep.
too.
Everybody reads
Okay.
those notice of privacy practices, right?
Right, yeah, read every that's I'm like, I bet it was on there. Yeah. Okay.
Yeah.
Okay, thank you.
Thank you, Beth, and thanks for that input on WIC. If it's all right, I'd like to schedule a call
Yeah.
outside of this and learn more about the value that you're
Yeah,
in.
absolutely. That
Appreciate
would
the
be
additional.
great. Do you have my email or do you want me to add it in the chat or I mean
Yeah,
I
Throw it in
got
the
great.
chat, Beth, and I'll
sure.
I'll I'll follow up post meeting.
Okay, sounds great. Thank you.
Thank you.
Thank you. Any other? I saw one or two
We
people come off of hiding their video.
and we
I
got
also
one in
want to
the
be
chat too.
respectful of your time. If you don't have any questions, we do not need to sit here for another half hour.
Steve, I got one in the chat. I'll
Okay.
just read out from Melissa. How is risk adjustment access impacted by payers who have single sign-on access? Do they still need to send a separate roster?
No, the existing roster and Melissa Albies, I assume,
Yep.
is who asked that.
Yep.
Okay. Hi, Melissa. So what you can expand on your roster, but I am not I'm not the one that can answer the question about single sign-on and the implications of single sign-in related to risk management. I'm not sure how that mechanism and functionality flows. Laura would be, again, the best suited to answer that. And if she's
I'm
offline right now, we can
I'm back.
schedule. Oh, there's Laura. Hey, Laura.
Okay,
Can you
what was the question about?
Laura, it's
single
Melissa
sign-on?
Albies. I was just wondering, so for payers that have single sign-on access, right? We have access through the members record
Hmm.
name. For when if we want to add risk adjustment staff to review that, do they need to do a separate roster and have a separate login, or can they access the record through that single sign-on link because we've already done the roster sharing?
If it's the same roster, the same patients, what I would need to do is work with your organization on the user ID that would be affiliated just with the risk adjustment. So there is a little bit of work to be done on both sides, but it's not significant. So if your organization wants to do that, when those become effective and want to implement a single sign-on for that staff, just let me know and I will work with your IT on getting the single sign-on for that particular role. The single sign-on itself is role-based, so I just need to set up an account for that, and then we need to make sure that they're mapped appropriately on your side.
Well, Laura, that's I guess we're confused because we do the security settings within our EMR,
Hmm.
right, of what they can have access to.
Right.
So we could give them access. I mean, I guess we can connect offline too,
Yeah.
for
So
just how we could track that.
yeah, the way your single sign-on works is there's different roles that are assigned a user ID. That's all done behind the scenes. So you set up the users and everything on your side, but I set up the role that they'll access and the data they'll access once they're in our system. So there's the two pieces like that, and that's how we did that. So it like I said, it's pretty simple. It's just we just need to coordinate.
Okay, I'll set up a call for us.
Okay, sounds good.
Thanks.
Hmm.
Thanks for the question, Melissa. Great one. And if anybody else is looking to set up single sign-on, especially from the health plan, let us know. Melissa is probably better suited than anybody to talk about the efficiencies of using single sign-on within your organization.
It's great. We love it.
Thanks, Melissa.
Hi, Steve.
Mr.
This is
Ballin? Hi.
Yeah. Hi, Steve. This is John from Quality Lead at CareSource, and we are actively working with WISHIN. And I just had a question around the Pop Health use case regarding the cancer registries. Will that include exclusionary information, whether the member has an exclusion for, say, cervical cancer screening or breast cancer screening or even immunizations? Um,
That's a great question, John. And currently we're not
Suggesting
participating
that.
in any data exchange or feeding into the registries. It is a topic of conversation as of late. But maybe Matt and Laura can add some color commentary. But today I would say that's not impacted just due to our lack of participation in those registries.
Gotcha. Okay. No, that makes sense. We can get that from the records, but I was just curious if that would be an item, in the future, as plans have to, they've opened up these measures now, to just beyond those sample sets. And so it's, all the eligible members in there, and some of those exclusions are helpful to remove members that are not eligible, um, and having to capture their compliance or their, screenings.
Would there be an opportunity, John, to schedule some time to learn more about what that process looks like for you? And then we can extend those conversations to the folks we're having discussion with at the cancer registries, or Matt, Laura, Greg, I might be butchering what organizations we're in conversations with.
Yeah, that's fine with me. Yeah, I mean, another person on my team that's working directly with WISHIN is Jackie Miller. I would certainly include her as well.
Fantastic.
Yeah.
Great. Thank
We'll
you, sir.
reach out.
Appreciate the question.
Yeah.
Yeah. Okay. Thanks. Yeah. Appreciate you. Okay.
Any other questions or things that we can help address today? If not, we are always available. Our contact information is on our website. Many of you know how to reach us directly. Otherwise, if somebody on the team can put our wishin email in the chat. Thanks, Greg. That will get to a few people that will then be able to disseminate that information to the appropriate person within the organization. And I'm not Faith. Sure, if if you'd like the slides, we can make it available. This recording will also be available on our YouTube channel. The session one, I believe, is already up there. Somebody correct me if I'm wrong, but this, just to be clear, this session is taking aspects of the notice that was sent, again, by email and by snail mail So all of this information exists within that notice that was sent to all organizations. But again, Faith, happy to send you any materials that would be helpful. All right. Last call then for any questions. I want to be, again, respectful of your time and greatly appreciate everybody's participation on today's call. We hope it was helpful. If you need to reach us, please do. We're here to help you. Thanks as always for being participants and trusting us as the Health Information Exchange. We will then close for the day. Have a great rest of the week and happy holidays to you all.
Thank you. You too.
Thank you.
Thanks, everyone.